Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th annual conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Oh, thank you, Debbie. It certainly is a pleasure to be with you this afternoon for this breakout session. Our session is titled Closing Data Gaps, Insights from GLP-1, Self-Insured Populations and Dental Care. This session was organized by Sarah Brewer and is moderated by Andrea Clark. Our sponsor for this session is Regence Blue Cross Blue Shield, and we would like to thank them for their generous sponsorship. Regence health plans serve 3.6 million people across 4 Western states. Recognizing that fragmented healthcare data creates barriers to quality care, Regence is committed to making its data more shareable and actionable across the healthcare system. Through these efforts, Regence aims to serve as a catalyst to transform healthcare, creating a person-focused and economically sustainable system where data drives better outcomes for all. So with that, let me go ahead and invite our moderator to the screen, Andrea. How are you today?
Hello. I'm well, thank you. How are you?
Fantastic. The stage is now yours.
Great. All right. Well, welcome, everyone. It's great to see about 57 people here. I'm Andrea Clark. I am the health economist for the CareQuest Institute for Oral Health, and I'm delighted to be with you here this afternoon. Just a quick reminder to put those questions in the chat. We've got some really interesting topics this afternoon that I'm delighted to share with you. So first, I'd like to welcome our first speaker, Ray Campbell, to the stage. He is the president of Fair Health, a national independent nonprofit organization that serves as a trusted leader in healthcare cost transparency, data analytics, and benchmarks. Fair Health possesses the nation's largest collection of commercial healthcare claims data, including over 51 billion claim records, growing at a rate of about 4 billion claims annually. They're certified by CMS as a national qualified entity, so they also receive data for traditional Medicare Parts A, B, and D. Ray is an attorney with extensive experience in public policy, health data, and executive leadership. Take it away, Ray.
Hi, my name is Ray Campbell. I'm the president of Fair Health, a national independent nonprofit organization that uses data to help healthcare stakeholders make better decisions. And it's my pleasure to be here to address the NAHDO annual conference on the topic of evolving applications for healthcare claims data. And specifically today, I want to take a look at our recent publication on trends in GLP-1 drug use, and also talk about a new publication coming up on chronic condition prevalence. So let me share my screen and we'll get started. So a little bit about Fair Health first. We are, as I mentioned, a national independent nonprofit organization. We have more than 52 billion medical and dental claims dating back to 2002. Our repository is updated on a monthly basis. We receive about 4 billion new claims every year. In addition to our commercial claims, we are a CMS qualified entity, and we have more than 53 billion Medicare claims from 2013 to the present, covering all 50 states. We have nationwide coverage for both our commercial and Medicare data. We have more than 75 voluntary data contributors, which I think is a strong vote of confidence from the industry in Fair Health's capabilities and value proposition. We have flexible geographic groupings so that we can present our data to customers and clients at the state level, the county level, GeoZips, and other custom geographies. And lastly, our data goes through rigorous testing and control to make sure that our clients and customers can depend on the data they get from us. So looking specifically at trends in GLP-1 usage, as I mentioned, so Fair Health produces price benchmarks for healthcare stakeholders. We produce custom analyses for various clients. We use our data to power a consumer transparency website, And then in addition, we also publish a variety of white papers and other publications, trackers and such, on important issues in healthcare. This spring, we released a paper that examined trends in obesity and GLP-1 drug prescriptions among commercially insured adult patients for the period 2019 to 2024, and it has some really interesting results. I can only go through a little bit of it today. I encourage you to go look at the full white paper on our website, as well as the many others that are out there. Okay, so just quickly going through some of the findings from the report. I won't have time to do justice to the full depth that's in there, but you can see here the strong growth in the percentage of adults that have a prescription for a GLP-1 drug. The blue line shows total usage going from below 1% to over 4%, and then the colored lines show the specific brands that people have prescribed, each growing over that same period of time. This chart shows the decrease, relative decrease. If you look at 2019, more than 40% of patients with a GLP-1 drug had only a type 2 diabetes diagnosis, and less than 5% had only an overweight or obesity diagnosis. Fast forward to 2024, and you see that it's the overweight and obesity only that has grown the fastest. There's also been moderate growth in patients that have both type 2 diabetes and an overweight or obesity diagnosis. And the only category where you've seen a decline in usage is patients with only a diabetes diagnosis. This chart, there's actually a lot to go through. I won't be able to unpack all of it, but it shows the percentage of patients prescribed a GLP-1 drug broken down by age. You can see it's far more prevalent among older adults in the 50 to 64 and 65 to 74 range. However, the table in the lower left is interesting. It shows growth by age groups over the 2019-2024 period. And you see that the largest percentage change has been in the 18 to 39 age group. This is a very interesting and concerning, but you want to have all the information out there to make informed decisions. This shows selected diagnoses that co-occurred before and after GLP-1 drug prescription among patients without a type 2 diabetes diagnosis. Now, this does not suggest causation. This would require further study, but you can use claims data to flag things like this, and you see some significant percentage increases in, for instance, just to take the first line, you see pancreatitis increased by 80% for patients before and or after compared to before taking the GLP-1 drugs. But it's from a very low level to a very low level. But still, it's a significant increase at that low level. And so this slide shows various other side effects that have been associated with GLP-1 drugs and showing the before and after prevalence. This slide shows percentage of adults with an overweight or obesity diagnosis and the people getting GLP-1 drugs and people receiving bariatric surgery. And so the blue line shows people that had drugs but no surgery, and that, of course, has grown sharply over the time period. And then you see bariatric surgery with no drugs declining over the period, and then also GLP-1 drugs and bariatric surgery remaining essentially constant at a low level. This is very interesting, and again, not to suggest causation, but just things that need to be looked into further. Percentage of adult patients that had an overweight or obesity diagnosis, looking at whether they received a behavioral health service. And what you see is there's a significant decline in the utilization of behavioral health services among those patients. And again, not to suggest causation, but it does suggest that there's something interesting that ought to be looked into further. All right, I should mention, so that's it for the GLP-1 study. As I mentioned, there's a lot more in there. Please go check it out. As an example of some of our other publications, we take a look at giving birth in the United States, taking a look at costs, but also demographic characteristics of mothers and families. We have an opioid tracker that sadly has received a lot of attention over the last numerous years that takes a look at a variety of metrics related to the opioid epidemic on a state-based level. And we have a telehealth tracker that takes a look at regional trends in telehealth utilization and the diagnoses for what types of diagnoses people have that are using telehealth services. And that's been widely received. And then lastly, I'll point out that we have a new publication that's going to be coming up this fall, followed by a website sometime next year, where we're going to be looking at chronic condition prevalence using our claims data. We're going to be using the definitions in the CMS Chronic Conditions Data Warehouse and our claims repository to report on prevalence of the following chronic conditions. Initially, we'll be reporting on it, and there'll be we can do a time series because our data goes back so far. So this will show change in prevalence of these conditions initially at a state level, but we're also working to produce this at a more smaller geographies as well. And that is my final slide. Again, thank you for the opportunity to present to NAHDO, a really great organization. It's great to be back, and I look forward to the question and answer portion of the program. Thank you.
Great. Thank you very much, Ray. As we're waiting for questions to come in, I had a couple of thoughts while you were speaking. So what are some other uses for your claims repository from like a population health or like a public health purpose? You really ran through some really good examples there. I was just wondering what other thoughts you might have.
Sure. So thank you very much for that question. It's a good one. Our claims repository, as I mentioned at the beginning of my remarks, is quite large. It was assembled originally, if you know Fair Health's origin story, to produce price benchmark reports for both health plans and provider organizations and government agencies and other participants in the healthcare system. But over time, we've been able to start looking at that data and using it for other types of studies, such as looking at the opioid crisis, looking at the utilization of telehealth services, cancer in young adults, a whole variety of other services. And then the last slide that I showed in my remarks, that's something we're very, very excited about because we'll be able to show the prevalence of between 40 and 60 chronic conditions and how they varied over time at different geographies across the United States. So lots and lots of different uses for this data that was originally assembled specifically for price benchmark purposes and is now, we're expanding very specific uses. We're, constrained by our data use agreement, so we're not using it for any and all purposes, but we are expanding into some of these population health use cases.
Great, thank you. We have a question just came in from our viewers from a Julie Saunier, which I apologize if I'm mispronouncing that. It says, how complete is the Fair Health database and how does this vary by state or region?
The database is quite extensive, but as I said, it's voluntary participation. So unlike, for instance, an all-payer claims database, where actually previously I was at the Center for Health Information and Analysis, CHIA, in Massachusetts, we could compel submission of data. So other than the Gobeille issue, you had essentially complete coverage. With Fair Health, it's voluntary participation, but we do have statistically significant representation in all 50 states. So it's a very significant database, but there is some amount of variation by state, depending on the participating payers.
Thank you. Great. Let's see. One more question for you. What are the advantages of claim data over, say, the federal hospital data and health plan transparency data?
Thank you for that. I get that question a lot because, and we're taking a careful look at the federal transparency rules and the data that both hospitals and health plans are posting in response to those regulations, and then beyond that, there's a whole ecosystem of vendors that have arisen to take that data and turn it into usable information for the industry, and that's great. We salute those efforts and think it's great as far as it goes. But if you think of what the federal regulations are trying to accomplish, because it very much has a consumer focus, and so they're trying to simplify the complexity of healthcare pricing down to essentially a menu, that there's a procedure and there's a price. So kind of that level of clarity and consistency, and that's great. What claims data gives you is, instead of a menu, it's all the receipts in the register. And so it's wonderful to see the menu. But when you have the claims data, you can see, frequency of the service. You can see I'm now completely mixing metaphors, but with claims data, unlike tick data, you have demographic information about the people receiving the services. You have information about the data service. You have information about, comorbidities and diagnoses and things like that. So although TIC data, transparency and coverage data, the health plan data, is an important and valuable resource. I think it can never replace and can never duplicate the power of a claims repository such as an all-payer claims database or a Fair Health repository.
Great. Well, thank you very much. Oh, hi. And Sylvia Hobbs of CHIA has just asked, what is the difference between Fair Health and Meritive Market Scan in terms of commercial population-based data representativeness?
Hello, Sylvia. Wonderful to see your name on the screen and to get a question from you. I hope you've been well. Sylvia and I worked together at CHIA. I don't know, that much about Market Scan in terms of one of the issues that we confront is that Fair Health is a nonprofit, and a lot of the commercial vendors in this space make some, pretty remarkable claims about their data. And in fact, I recently saw one where somebody claimed to have trillions of records, which I'm just not certain how that's possible. Unless I'm not sure what type of records would add up to that. But in any event, I don't really know what Meritive Market Scan has in terms of the data representativeness, and I don't even know how much they've put out on that. Fair Health, as I said, we have 50+ billion commercial claims, and we're a CMS qualified entity, and each of those individually is statistically significant in every state, and together gives you even more power. So I hope that answered your question, but great to hear from you, Sylvia. You're a star.
A follow-up to that. Last time I was in the Meritive data, one thing I ran into was that sort of they have, I think it's 16 states worth of the Medicaid and then just a kind of a similar geographic scope on the commercial side, but you can't tell when you're looking at a set of claims what their geography was. Here I have one of their Medicaid data sets, and I've pulled because I work for CareQuest, I pulled a bunch of periodontal claims, and I can't tell what states those folks are in. In Fair Health, do you have geography identified?
Absolutely. What we don't do, we don't allow, because of our data use agreements, we don't allow researchers claim level access to the data, but we do, you can construct the for kind of acceptable uses of the repository. You would, can construct the query, we can run it against the data, and yeah, we certainly have granular, we have 5-digit zip codes from the data. And so we map it into 3 digits. So I think that's kind of the most granular geography we use.
Right. Yeah. Well, thank you. And Mark Moffat from our audience asks, I wonder about the extent to which the increase in comorbidities associated with GLP-1s are an artifact of prior authorization requirements.
It's a great question. And I said it a few times in my remarks, and I want to emphasize it again, that what we've done are kind of a first pass analysis looking at claims data, but there are many things that go into this. So coding intensity, the pandemic was in there. There's all kinds of things that would potentially impact kind of the numbers that we were showing. So we think that they point to areas that deserve further research. But as I said, I don't think you can take them at exclusively at face value, because there have been so many things happening within healthcare and within the country at large over the period of time we were looking at. So it's a good first pass, and I think that you need to follow up with more detailed evaluations.
Yeah. Thank you.
You're welcome.
Okay, shortly to be joining me on stage are our presenters for our next presentation on self-insured populations. And they are Katie McGraves-Lloyd, a principal health data analyst at Onpoint. She specializes in advanced statistical analysis and health analytics. She spearheads data collection and analytic projects, including program evaluations, primary care profiling, and complex data linkages. Ms. McGraves-Lloyd excels in statistical modeling, predictive modeling, and developing risk adjustment models, particularly for comparing claim and non-claim data. She has an MS in Applied Statistics from the University of Southern Maine and a BS in Biostatistics and Public Health from Simmons College. Jennifer Perloff is a senior consultant at Onpoint with more than 20 years of experience in health services research, payment model evaluation, and healthcare claims analysis. She has led major studies using Medicare, Medicaid, and commercial claims to assess care quality, alternative payment models, and the cost effectiveness of care delivery. At Onpoint, she provides strategic guidance on analytic design and product development, leveraging her expertise to support impactful policy-relevant insights. Dr. Perloff holds a PhD in social policy from Brandeis, an MPA from Cornell, and a BA from Bates College.
Welcome to our session on imputing the missing ERISA population in state all-payer claims data sets. So today we'd like to cover some background on this issue, present some methods for imputing the missing population, compare two approaches, and share some conclusions. So by way of background, we at Onpoint are increasingly hearing from clients that they want to address this ERISA missing population. And so we've been investing some time and resources in developing methodologies. The work today, we'd like to thank some colleagues who aren't here, Hiroko Mazurv and Kate Ahrens. So what's included in an APC data set? Well, the core data are commercial claims from fully insured employers, Medicaid, and Medicare, but there are some important gaps. So what's missing is the commercial self-insured population, which we'll talk more about, military and veterans, workers' comp, Indian Health Service, uninsured. There are many populations that are missing. So the largest missing population is that self-insured group. And how did we come to be that they are not included in APCDs? Well, there was a lawsuit, Gobeille versus Liberty Mutual, that went all the way to the Supreme Court. And the issue was whether these ERISA employers needed to report their data to these state-mandated data sets. And in March 2016, the Supreme Court ruled in favor of the plaintiff, and self-insured employers were no longer obligated to submit data. So that created a large hole in state all-payer claims data sets from 2016 forward. So the result of this decision is that there's now a big hole, and in some states it can be as much as 40% of the commercially insured data that's missing. So this creates a big problem that we need to solve. And so the issues that come into play here, first of all, we have no visibility into these self-insured employees, but this then causes problems when we're trying to estimate statewide utilization and cost, and it also makes it harder to justify the existence of the APC data over time. So really solving this problem really helps us defend the use of APCDs and their value to health policymakers. So I'd like to now turn things over to my colleague, Katie, to talk about two methods developed at Onpoint. Katie, take it away.
Great. Thanks so much, Jen. Okay, so what can we do about the missing self-insured population, and how can we report from APCDs given this gap? So there are three ways. So you can report the data as is with the necessary caveats. You can stratify by major payer. This approach avoids a total amount, which may be lower than a true state amount. And this may spur questions about the validity of the data if an external party notices that the ends are wildly different. Or third, you can take an approach we'll talk about today, where researchers apply an imputation to estimate the missing self-insured population. So we're going to talk about two approaches. I'll describe them both at a high level here, and then we'll walk through detail in subsequent slides. The first method is to use the total population from a source like the ACS to weight the commercial population in the APCD up to the true commercial population. The second method centers on identifying the leavers. These are people whose data was present in the APCD before Gobeille and then disappeared after. Once we have the pool of leavers, we identify their cost and enrollment pre-Gobeille and use growth factors to project them forward. So I'll talk about method one in more detail. First, an estimate needs to be identified for the total commercial population. This can be done using the American Community Survey, or the ACS, managed by the U.S. Census. Here are a couple of screenshots of the data source we use for this analysis. We use the HI05 data source, you can see in the upper right. Beyond the ACS, other data sources could include the Medical Expenditure Panel Survey, MEPS, or Healthcare Cost and Utilization Project, HCUP. So first, once we have the population of the commercial from the ACS and from the APCD, we're going to calculate a factor, which is the total commercial population estimate divided by the commercial members in the APCD. In this case, it's 4.5 million divided by 3.5 million for a factor of 1.29. Once we have this factor, you can apply this in a couple different ways. We find the most beneficial way is to a person-level file where each commercial person counts 1.29 times. For example, if you use average member months as a denominator, so average member months would be member months divided by 12. A person with 12 months would normally count as 1. 12 divided by 12 is 1. A person with 6 months would count as 0.5. 6 divided by 12 is 0.5. If we apply the weight, a person with 12 months would count as 1.29, and a person with 6 months would count as 0.65. So we're essentially upweighting the commercial population in the APCD to equal the total commercial population. The benefit of applying at a person level is that all the downstream stratifications and roll-ups include this adjustment. Alternatively, you could apply the weight at a final step of an aggregated analysis. Our approach has been to do this at the person level. So a couple notes on this approach. This method assumes self-insured members are identical to other commercial members in cost, benefit, and design, which may or may not be true. A state could validate this assumption by calculating PMPMs and demographic distributions for self-insured versus not self-insured members. And as I mentioned, once we have this factor, you could apply it in a couple of different ways. You could use this as a multiplier for aggregate results, or you could use it at a person level and then calculate your roll-ups. Next, I'll talk about the second method, the levers approach. So I'll talk through these high-level steps and then go into more detail on each one. So first, we identify the levers. These are people who existed in the APCD in 2015 and then disappeared after March 2016. Second, we calculate the PMPY cost and the number of enrollees in that lever group. And lastly, we use appropriate growth factors to trend the enrollment and cost information forward. So in order for a state to identify the levers, there must be significant historical data, pre-2016. It's helpful if states have the coverage type field to be able to identify self-insured members. That's the second sub-bullet, coverage type field in ASO and ASW. And it works really well if states have the group name field to identify specific employers who drop out. It also works well with submitter. So if a state doesn't have group name, you can look at how the population changes within a submitter. So in my graph on the right, this is just sample data, which shows that 2/3 of submitter one's population dropped out in April 2016. If you're using the group name, you can look if like a large university or employer drops out. So once we have established our pool of levers, we calculate their cost and we already have their enrollment. The last step is to trend the numbers forward. So we use enrollment specific figures and then we use cost specific growth rates. So this slide is dealing with enrollment and projecting for the enrollment number for the leaving group. So for enrollment, the growth rates could come from MEPS or state NAHDO. National growth rates would assume that the state enrollment is the same as national. So we think it's best to use state specific figures when possible. If we walk through a specific line, we have 1 million leavers in 2015, and then our enrollment growth rate in 2016 is 4%. So we multiply 1 million times 1.04, and then our estimated number in 2016 for this group is 1,040,000. This slide is the same concept, just with the cost. So we have the PMPY, and we're using cost-specific growth rates to trend these numbers forward. We think the best growth rate comes from the APCD itself. It can come from the commercial members in the APCD. You can use the people you have in the APCD and calculate the growth rate and use that. If not, you could use state NAHDO figures or a national source. State NAHDO is only current to 2020, so that won't give you the full picture. And if you use national, you're assuming that your state growth is the same as the national growth, which may or may not be true. So some comments on this assumption. This assumes that the members left and never came back. And if you use national growth rates, you're assuming that the growth nationally is the same as in your state. So let's close by comparing the two approaches. So both of these have assumptions. Method 1 requires the least amount of data and effort. It requires only the total number of commercial members in a year from the ACS and the APCD. So if a state doesn't have significant historical data, doesn't have a lot of time or resources to invest, this is a great approach. The second method requires significant historical data that must include 2015. It also requires the ability to isolate the levers by using group name or submitter, and coverage type is a nice addition to segment the self-insured population. This requires more computation, more time, more analysis, looking at groups that dropped out and making decisions about the lever group. So in conclusion, there are multiple methods that can be used to impute the missing ERISA population state APCDs. Each method has trade-offs. Not all APCDs will have 2015 data for imputation. Future research could consider use of newer data sources such as health information exchanges to help estimate the utilization for populations missing in the APCD. And so thank you. We are happy to take any questions you have.
Well, thank you both. That was really interesting. One thing I was wondering is, listening to your presentation, is how should a state or a researcher choose their method for imputation? I know obviously there's the effort piece that you spoke of at the end of your presentation, Jennifer. But any other thoughts that you might want to share?
Yeah, definitely effort. I think also your end goal. So what I really like about the weighting approach is that you have a person level file with a weight applied. And so you could do any sort of roll up you wanted that existed in that person level file. So for example, you could do reporting by like geography or other member factor. Whereas like the lever approach, it's harder because you have these aggregate figures and you haven't estimated at those particular strata. So I think it's definitely the resources you have, but also like the end goal and what you're trying to do with it can help you decide on the approach. I don't know, Jen, if you have thoughts on that.
No, I think that sounds great, Katie. And I think it's worth pointing out that, the Gobeille decision was a while ago at this point, and those data are getting older and older over time.
Yeah.
And so method one definitely uses more current data. But yeah, I think those are great thoughts, Katie.
Great. Awesome. We've had two questions come in from our audience so far. First, Sylvia Hobbs from CHIA. Wouldn't it be methodologically feasible to impute missing self-insured data in the state level APCD by comparing state level longitudinal emergency department visit volumes from APCD with the nearly complete case mix outpatient and emergency department data, producing accurate aggregate level estimates of self-insured under capture while avoiding unreliable and legally constrained person level imputations?
So I don't I just have a couple thoughts without completely understanding what's in the case mix outpatient emergency department data. So do you have that broken out by specific insurer? Because then you could do like a commercial to commercial calculation. If not, that would be a more aggregate number. I don't know, Jen, if you have thoughts. I'm just thinking through the question.
Well, and I think it's a great point that there are other data sources that do include the ERISA population. And so Sylvia is, for example, pointing to one source that would include those beneficiaries. Katie, you mentioned the National Health Expenditure data includes everyone in a given state and in the country. So those are certainly strong sources of data to draw on in this type of imputation work. So I think it's a great idea.
Yeah, and Sylvia's responding yes, and I think that's yes to that in their case mix data in Massachusetts, they can observe the difference in insurance type. I know they have, the self-pay and so forth, which is one of the really cool things about, case mix and hospital discharge data and so forth.
Yeah, that's great. That's Julie, a great option. Sorry, go ahead.
Julie Saunier asks, both of these methods seem helpful if you need to calculate total spending. But what if you need to do a detailed analysis by service, for example, heart surgery or a geography within a state? It's a good question.
This is where I think method one is helpful, because you have a population where you've weighted people, and so each person in your data set. So you're essentially using the data set you have, but each commercial person counts more. And so I think method one would be applicable for an analysis by geography. Do you have other thoughts to add, Jen?
Yeah, again, really great question. And I think one of the challenges, we don't know how that self-insured population differs from who remains in the commercially insured. And to the extent that they're the same, this weighting method is a perfect solution, but also, ongoing research to understand the characteristics of that missing population. Are they clinically the same? So additional data definitely could help inform that kind of added imputation.
Yeah, that was actually the follow-up question that had occurred to me from this conversation was if you at Onpoint had any opportunity to explore if that assumption, how robust is the assumption of the SI population, being largely similar, in distribution and characteristics to the fully insured population, or if you had any thoughts about how one might approach that question. It's really tough with that, given the censored data problem, but I'm just interested in any thoughts.
Yeah, I think there's a couple ways you can evaluate similarity. One of them we've done is by age and gender. So we found some statistics statewide and we created age bands like 1 to 17, 18 to 34, and then compared for the like known population we have in our benchmark, look at the distribution of age, and then look for that leaver group. And they're actually pretty similar. It's like within like 1 or 2 percentages at that sort of like age bucket approach.
Really interesting. Okay. These are some really great questions. Any thoughts on validating whether your method is working appropriately? So I guess it kind of dovetails with the question I just asked. Yeah.
Yeah, definitely. I think that probably the perfect solution would be if you're able to look at your estimate versus the actual data. So if a state has data going back to like 2013 or 2014, maybe you could apply these imputation methods, look at your imputed values, and then compare it to the actual values because you have them, because they haven't left yet pre-Gobeille. So that might be one option.
And as a health services researcher, I was just going to say it's definitely an area that's worth further research, for sure.
Yeah. If you're going back to, it was just occurring to me, I was reliving the trauma of 2015 with the ICD-9 to ICD-10 switch. So you've got to be, if you want to go back and get those Gobeille folks, you gotta be willing to wrestle with that. But well, thank you both very much. This has been a fascinating conversation. Appreciate your time.
Thank you.
All right, and our final presentation today on dental data, which is near and dear to my heart and my colleagues here at the Institute. It was by Sarah Crawford from the Arkansas Center for Health Improvement. She brings a strong background in healthcare data analytics and plays a lead role in guiding analytic development projects at APCD. She is responsible for creating research data sets and producing outputs focused on service utilization, access trends, and workforce capacity. Her work informs key deliverables, including interactive dashboards, summary reports, and policy-facing materials. She has over 7 years of experience working with large healthcare data sets, including claim and provider files. Take it away, Sarah.
Hi, I'm Sarah, and I'm a senior analyst at the Arkansas Center for Health Improvement. We're a nonpartisan independent health policy and research center. We were established in 1998 to create an intersection between research and policy within the state. We work to support research and health policy by using our experience in the management and integration of health data. And we are the administrator of the Healthcare Transparency Initiative, and we manage the Arkansas All Payers Claims Database. Today I'm going to speak about a project that we did here at ACI incorporating medical, dental, and pharmacy records from our APCD in order to answer some questions regarding how oral health relates to other health services. While the mouth and teeth are part of the body, dental care is not typically insured in the same way as medical, but leaving dental issues untreated can have a major impact on overall health. Many people do have both medical and dental insurance, but they don't use them in the same way. Maybe they don't know how to, maybe they don't realize that they have the coverage, maybe there's an access problem and there isn't a dentist available where they need them. In 2022, ACI put together a report based on data from 2019 using the Arkansas APCD. Our APCD includes medical, pharmacy, dental, member, and claim records. And we use them all in order to produce a report profiling baseline levels of dental care utilization and how they relate to a few other medical and pharmacy health metrics. The first thing that we did was identify the proportion of Arkansas residents that had evidence of dental coverage in 2019 in the APCD member data. And the Arkansas APCD all member records for medical, dental, and pharmacy are combined into one member file. But we needed to identify plans that were either dental-specific plans or plans that included dental coverage. We found dental coverage at some point in the year for just over 50% of the Arkansas population, and that proportion generally declined with age. So these maps show the variation in coverage and utilization by county for dental services. The map on the left shows the percentage of the population that we were able to identify dental coverage for in the APCD for 2019. And the map on the right shows the percentage of dental insured individuals in each county who had at least one dental claim of any type in the same year. When you compare the two maps together, you can see that the people with dental coverage are often not using it. For example, you can see some of the counties there in the southeast corner of the state that have comparatively high amount of their population with coverage in the map on the left. And then on the map on the right, those same counties have some of the lowest rates of utilization for the state. There are other counties like Saline in the middle of the state that have lower insured rates, but those that do have it there appear to be using it more. Based on our observations regarding the southeast corner, we also looked at dental provider availability to see where there might be access issues. This map shows the number of residents per dentist providing services to at least 1,000 unique individual patients in 2019 within that county. So the denominator is the number of residents living in the county from the ACS, and the numerator is the number of dentists who provided services within the county. As you can see in this view, there are a number of counties that do not have a dentist that is serving at least 1,000 patients within that county. Some of them line up with what we saw in the previous set of maps. The counties in the southeast have few or no dentists, as well as the north central and west central part of the state. People living in dental deserts would likely have a harder time visiting a dentist for preventive care, and we expect that people that aren't getting preventive care will develop issues that will get worse with time, potentially triggering a medical event. So we investigated members who were seeking treatment for dental issues in medical settings, such as in their primary care office or in emergency rooms. And we looked at the medical claims for diagnosis codes beginning with K0, which indicate disorders of the teeth. We wanted to see what kind of diagnoses they were receiving in those medical settings, and then for those that were seeking medical care, whether they had dental coverage. If they did have coverage, we wanted to know if they had any preventive care through their dental provider in the year prior to seeking that medical care. This required linking individuals' medical and dental coverage and using both claim types along with their member records to examine these individuals' complete oral health experience. When we extracted medical claims with a primary or secondary diagnosis starting with K0, we found the most common ICD-10 diagnosis codes relating to dental issues were ones that are typically preventable with a regular dental care and services, which you can see here. Dental caries or cavities were most frequently diagnosed, followed by diseases of the pulp and periapical tissues, and then other disorders of the teeth and supporting structures. So this pie chart shows the dental insurance coverage status of those patients who did incur a medical claim for any dental-related issue in 2019. 72.9% of these individuals had evidence of dental coverage in the APCD at some point in the 12 months preceding their medical event. Since many of these individuals did have dental coverage, the question became, were they using it appropriately? For those who had access to both medical and dental coverage and sought care in medical settings, we looked back over the previous 12 months to the date of that medical visit to determine how many of them had any preventive dental visits in that period. For kids covered under Medicaid's Arkansas Kids program, we found that a slight majority, 51.4%, did not have a preventive visit in the previous 12 months. However, among those with private Medicaid fee-for-service or Medicare Advantage coverage for dental, children and adults, the vast majority had no evidence of preventive visits in the 12 months prior to their medical visit. This does really underscore the importance of those routine visits to avoid downstream bad outcomes. In addition to linking members' medical and dental history, we also linked between dental and pharmacy records in order to have a look at opioid prescriptions related to tooth extractions. Because of wisdom teeth extractions during the teen years, opioid prescriptions from a dentist are often an individual's first encounter with opioids. As recently as 2017, dentists were the second leading prescribing specialty of opioids by volume, led only by internal medicine physicians. The National Opioid Public Health Emergency was recently renewed, and this is a source of prescriptions that shouldn't be ignored. We identified individuals in the dental claims who had a tooth extraction in 2019 and then found their pharmacy member record to extract their pharmacy claims and see if they were filling an opioid prescription. Of patients who had a tooth extraction, the average proportion who filled an opioid prescription as identified in the individual's pharmacy claims was 23.3%. The highest rate was for 15 to 19-year-olds, which is a common time for individuals to have their wisdom teeth removed, and 58.6% of those teens getting extractions were filling an opioid prescription. The proportion of these individuals filling an opioid prescription and related to a tooth extraction generally decreased as the groups increased in age. When dentists prescribe opioids, they should follow the CDC guidelines and prescribe not only the lowest effective dose, but also no greater supply than what is needed to effectively manage the acute pain. A supply of 3 days or less is often sufficient for these extractions, and a supply of more than 7 days is rarely needed. The majority of prescriptions, 55.6%, were for 3 days or less. Only 4.8% of opioid prescriptions filled for tooth extractions were for 7 days or more. We are currently working on an update and expansion on all of these measures, and results of those studies will be coming out over the course of the coming years. We'll be pursuing more in-depth research on provider availability and access. We'll work on the linkage of additional social determinants data, further linkage with medical claims to assess impact of dental care and oral health on overall health, and also trending all these measures over time with creation of dashboards for visibility and potential policy implications. So this was all funded by the Delta Dental of Arkansas Foundation. The report supports improved dental care utilization and oral health in Arkansas. And you can see the full report on our oral health landing page, which is listed here. I would encourage you to visit, as there is a lot of information covered there that I was not able to get to here today. And that is all.
Well, thank you, Sarah. Excuse me. As we wait for Q&A from the audience, I was wondering, were there any preventive dental services that medical professionals have been encouraged to perform in Arkansas?
Yeah, we looked into something that was being transitioned to being pushed by dentists and dental associations in Arkansas for pediatrics specifically. They were wanting more doctors to perform fluoride varnish application. Yep. Kids are supposed to get at least 2 fluoride varnish applications in a year if they are low risk for like cavities and stuff. And if they're at high risk for cavities, they're supposed to get 2 to 4 applications. So if kids are going to the dentist twice a year, which a lot aren't, then hopefully they're getting 2 applications. But if they're not going to the dentist at all, or if they're only going once a year, it can be really helpful if the physicians are also providing a fluoride varnish application when they go for like their wellness visits and stuff. So we did look for those. I think in like 2017, there were new codes, procedure codes for doctors to use for fluoride varnish applications. And so we did some trends over the time period, I think between 2014 to 2020 or 2021, one of the two, I don't remember. But to see the uptake of that in the physician community and like what providers were doing that. And we did see a large increase in doctors giving those fluoride varnish applications as well.
Great. Okay. Yeah, thank you. Yes, there is a CPT code as well as the CDT code for fluoride varnish, and in every single state under Medicaid and CHIP, kids have coverage for fluoride varnish application on both the medical side and the dental side. And as community water fluoridation comes under a threat in a variety of jurisdictions, it's becoming more important than ever. It's an issue that we spend a lot of time thinking about at the Institute. So thank you for raising it. Did you see a difference between how urban and rural areas are utilizing dental coverage for preventive care versus restorative and other treatments?
Yeah, we did see a little bit of a difference between urban and rural members. When looking at preventive services, more people in urban areas that have coverage were getting those preventive services than people who lived in rural areas. But then when you went to restorative services, cavity fills, things like that, they were pretty much even. So people in rural areas were getting those issues when they did arise. They were seeking the services to fix the issues that they were having, but they weren't seeking preventive care as often as people who probably have easier access living in an urban area.
Right. Yeah. Very interesting. Thank you very much. Well, and now it's time to bring all of our speakers onto the screen and on stage, as it were, and to take any more of your audience questions or any discussion. For our presenters, thank you all very much. It's been just really a great conversation and great topics. Any questions for each other? Sorry to put you on the spot. Oh, I have a few more. I was wondering, Sarah, do you have Medicare Advantage in the Arkansas APCD?
Yeah, we do. Mm-hmm.
Okay. Yeah, I was wondering about, you're talking about the decline with as people get older, of whether you're seeing that dental coverage, and a lot of Medicare Advantage, in fact, has dental, but there is a utilization issue where people don't know how, don't know that they have it. So it's a utilization gap. And of course, traditional Medicare does not offer a dental benefit except in some very limited medically necessary circumstances. Kedley is asking some questions. Dental data is not widely received in ABCDs across the country. Did you find the dental coverage was sufficient for Arkansas, and what gaps did you identify?
Yeah, we did. So we did find that a majority of people that we have, we did find the majority of people we have dental coverage in the Arkansas APCD compared to like the population. It is less than those who have medical coverage, obviously, but it is quite a few. At this point, most people with Medicaid do have dental coverage, and most people that have Medicare Advantage do have dental coverage, and so we did find that we are seeing the population having the coverage. It's just whether or not they're using it, and we do have in the report the breakout of that by county as far as like how many people have it.
Great. Well, thank you for that. So, Ray, with your GLP-1 research, I was interested. So I was interested in that pancreatitis result. Do you know, or other researchers, have they do they know? Is it just because of the stimulation of the pancreas may become problematic for some people because the overproduction of insulin?
No, so that's an example of where we've simply flagged kind of the spike in the claims data, and of course, so it's not and there could be coding intensity, there could be any number of things that drive.
Right.
And so it's kind of it's an early warning system or a signal detector or something like that. So I think that our data can detect things that need further examination, but I wouldn't want to there's depending on the nature of the analysis, I think you have to be quite cautious about drawing strong conclusions. And I think that particularly when you get into clinical things, like, is there a causal relationship in terms of the increase in pancreatitis and other things? But I think you'd certainly want to look into it and have clinical data, at your as part of that analysis.
Yeah, that's actually an excellent, really excellent point about the coding intensity. Because if you were someone's physician and you knew they were on a GLP-1 and they were describing symptoms that could be pancreatitis, you might be more likely to then go ahead and place that code in their file, thinking that, almost kind of in a similar logic of the early warning. It's a really good, really interesting thought. Thank you for that. I was also curious with Katie and Jennifer around the self-insured. So what have you had the chance to look at in terms of, and how are you handling it? It's now I've been out of the APCD, being hands-on with APCD data for a couple of years now, but in the work that my old team used to do, we were very cognizant of the developments in the commercial market toward the SI percentage, the self-insured, proportion of coverage, generally was increasing over the years, and had reached, I think we were assuming something like 51 or 53%, sort of in the early 2020s. Have you seen that trend continue to grow? Do you expect it to? How are you accounting for that in the analysis?
Yeah, I think that there are a couple data sources you can use to evaluate that. So MEPS has some enrollment figures that show commercial, and then they also show like the self-insured, like employer sponsored or not employer sponsored.
Mm-hmm.
And so that can be helpful to gauge how things are changing over time, like using a national data source. I think that that's generally how we've looked at it, is like we have to use benchmarks because obviously it doesn't exist in the APCD. Right. I don't know, Jen, if you have anything to add.
No, I think that's great. And we've talked about the importance of all these sort of external data to understand the completeness of the APCD. So definitely the more data, the better.
It's just like another thought, since no questions have come in from the audience. I think what I've thought about as I've worked on this project is, how do we know when we get it right or close enough to right? Obviously, these are all estimations and it's built on huge assumptions. And I think that if you're able to run it historically and like look at the actual data, like that's great. If not, do you have some sort of external benchmark you can compare to? And if not, maybe you have to create some sort of measure from the APCD information you have. I was just looking at something this morning where I was comparing two methods and thinking like, well, I don't really have an external benchmark, but maybe I could look at like the cost per member and see how similar or different they are compared to the cost per member in the APCD. So I think lots to evolve here, and things to look at, but these are questions we get asked from multiple clients, and some people on this platform may know about our collective impact initiative, and we are incorporating this in our collective initiative. Sorry, Sylvia, I see your question. If you could offer words of encouragement to carriers, how would you convey the potential downsides or risks? Yeah, encourage them to voluntarily submit it. I think I might approach your question a little differently. I think sometimes when we're in some sort of negotiation, we want to think about what the other person wants, what the other person can get from this. And I think that that's kind of how you have to approach the conversation. And you could pull up, like, at Onpoint, we do a lot of reporting for like employer groups, or we could say, if you submitted this, you could look at cost, you could look at all this information and be able to like manage that really well for your population. And so I think that the submitters probably aren't going to care about like the nuances of an imputation method, but they're going to care about like reducing their cost for their population. So I don't know, that's my thought. Jen, do you have anything to add to that?
Yeah, I mean, my head goes in a slightly different direction, which is, demonstrating empirically how these groups are the same or different, and bringing data to the field to say, look, adding your data completes our picture in valuable ways. But absolutely,
Yeah.
Katie, I think your approach is perfect.
Norm, do we have a opportunity for one more question? I think Sarah had one.
Yes, it'll be very quick. We can do one more.
Okay, this is just, it can be real quick. Ray, I was just wondering, when you did your comparison, like conditions before and after the GLP-1, was that like a standardized amount of time? I saw you had like the years up there, but like from when the person first started their GLP-1, and also like, was there any kind of standardization of like how long they took the GLP-1, or was it just like if they got one, then they were in, anything like that?
I'll have to. I mean, I'm I'm the president, not the and I did not actually perform the analysis, and so I believe that it would be standardized time frames that would be used for the analysis. But let me talk to one of the elite analysts and send you some more information by email.
Right.
Okay.
Awesome.
Thank you, Andrea. Thank you, everyone.
Yeah,
Just
thank you.
let everyone know what's coming up next. We have our closing plenary panel. This is the very last chance to learn something fabulous and new. And we're going to a deep dive into NAHDO's APCD CDL. So if you are ready to geek out on standards and that sort of stuff and what it can be used for and all of that sort of stuff, this is the chance for you. We've got some of the main leaders, thought leaders and architects behind that. It is a blueprint for collecting claims and non-claims payment data. So if you're also interested in non-claims payment, here's a chance for you to as well. So anyway, thank you all for your comments, for your questions, for your participation. It's been a fabulous session, and we will see you all again soon.
Thank you, everyone.